Welcome to The Digital Patient, where we discuss the latest advancements in digital patient engagement and share stories from the front lines. I'm your host, Sardana, and with me as always is SeamlessMD's CEO, Dr. Joshua Liu. Today we're joined by our very special guest, Dr. Jake Lancaster. Dr. Lancaster is CMIO at Baptist Memorial Healthcare. He's also the co-host of the Right Care at Baptist podcast and the Baptist Management System Connecting the Dots podcast, and is also the author of a new book, The Matter of Medicine. Dr. Lancaster, Jake, welcome to the show.
Thank you for having me. This is something I've been very excited about. It's going to be a great conversation. Looking forward to it.
Absolutely. We are so thrilled to have you on today. You know, we were talking off camera, but you are a pro at podcasts. So I'm so excited to have a conversation with you. I heard actually, and maybe I'm wrong, but I heard that you initially had wanted to pursue cardiology as a career, but then ultimately carved a significant path in informatics. So first question is that true? And then the part two to that is why medicine and healthcare in the first place?
Yeah, it is true. So, it started when I was in medical school. I actually did a lot of research with a congenital heart surgeon. So I thought I was going to go in that direction until I learned that surgery was not right for me and decided to go internal medicine with the plan of doing a fellowship in cardiology. And, really had that all throughout residency up until the middle of my second year. All of my research was in cardiology and was really looking forward to it. All my mentors and letters of recommendation writers were cardiologists. So it was the way I was going. But my second year of residency, I was allowed to do a master's of health administration. And I'd always been interested in the kind of the bigger themes, the ideas in healthcare, what else was going on in healthcare landscape. And so it was during that master's course that I started taking topics, and one of them was on healthcare technology and IT, and got really interested during that series on, the changing landscape in healthcare, how the digital future was going to shape it, and really wanted to be a part of that and grow with it and not be somebody that has to react to it. So did some digging and found out that there were actual ACGME approved fellowships for clinical informatics that had just really started. I think there was like 11 the year I applied, and was able to be the first fellow at Vanderbilt for clinical informatics, and kind of my career changed significantly since then. But yeah, it still, even during fellowship while I was applying, and I thought maybe I can find a combined program that also does cardiology. Maybe I'll do cardiology fellowship afterwards, but I was kind of hooked, I guess, once I was there, and didn't really look back after I got started.
Very cool. I was curious, the MHA, so health administration, like knowing kind of the holistic business side of healthcare, how does that inform your perspectives on informatics and how you're looking to approach all of the different problems that you're solving?
Yeah, I think it really helps from the informatics side. There was a lot I did not know when I was in residency, just having the clinical background about how healthcare operated and what the incentives were, what the economics of healthcare really was. And we just didn't get any of that in medical school. And I certainly did not have any business background in college. I was a physics major, and all of my undergrad was dedicated to basically pre-med courses in physics. So learning about healthcare operations, organizational and development, all of those things and how it impacted healthcare, and also just the interactions with the other students in the class about what they were thinking, what they worked on, and how there was just a large piece of the pie that was outside of direct clinical medicine really affects how I think about informatics. And really, it's almost hard to do informatics without that background. You would have to do a lot of learning about where the incentives are and what does the CEO of a hospital care about. We love to think that at the end of the day, we'll spend money on improving clinical care, but without the backside of what that ROI looks like and how to present that, it's more difficult to get initiatives approved. And I found that having that background really helps me get things moving, maybe easier than somebody without it.
Do you know, like in terms of the business of healthcare, the economics of healthcare, like as you mentioned, for a long time, that really wasn't part of the curriculum for training. In my time, it definitely wasn't. Do you know if that's actually improved? Like, are they carving out that time at all for current trainees?
I don't know. It's been a while. I know that we had some, they were not official courses. They were, kind of workshops or, extra sessions you could go to late at night on the business of medicine and what you needed to know about finances and how to run a clinic. And you would get 20 students to show up to it, but it was not something that was required. If it's not tested on in step 1, 2, and 3,
Sure.
med students aren't going to do anything about it, even though it's a huge need. But there's so many other things also that they try to load onto the medical students' plate. I was actually chair of our curriculum committee when I was in medical school. So, was trying to help shape that, even though I didn't really have much influence, but I would kind of provide the voice of the students on what we were interested in. At the time, it was more incorporating more behavioral health, more sociology type things into it, and also professionalism, things of that nature, and moving to more of a systems base than a pure subject matter base. So it has evolved some, but being able to include the actual healthcare operations, that sort of thing, I think it really does require you to do your own outside training.
It's funny because I think if you were to survey like physicians, let's say, 10 years into practice and ask them, hey, what do you wish you knew? What do you wish you were trained on during medical school and residency? I feel like some of these topics around the business of healthcare and other things would probably come to the top of the list. The question is, well, even if you taught that during training, would you really understand it until you actually had a practice? And maybe it's something that has to be learned while working. I don't know. It's a good question.
Today's episode is brought to you by DeepScribe, AI clinical documentation that physicians and health systems love, documenting specialty and complex care with ease and precision. Josh, have you heard all the buzz around ambient AI and virtual scribes?
Definitely. Clinicians are spending hours a day on documentation, so improving their day-to-day and reducing burnout is huge right now. You and I have seen quite a few product demos for ambient this year, but I have to say, DeepScribe was one of the most impressive.
Well, Josh, you trained as a clinician. What stood out to you most about DeepScribe?
Well, using AI to transcribe and summarize the clinician-patient conversation is honestly table stakes right now. But a big challenge for CMIOs and CIOs is driving actual clinician adoption. So what really impressed me about DeepScribe is how well it can be customized to different specialties and workflows with dozens of templates as starting points. That would be critical to me as a clinician because I just don't have time to build templates from scratch.
So true. For me, I was particularly impressed by the auditable notes. You can highlight any part of a note, and then DeepScribe shows you exactly where in the transcript the note was generated from. So you can find that evidence right away. That builds trust.
Oh, exactly. Being able to confirm that something wasn't hallucinated is so important for clinician trust and safety.
Yeah, that same attention to detail that led to really high clinician adoption is also resulting with clinicians saving up to 75% of documentation time.
Wow, that's incredible. But how is DeepScribe's accuracy with specialty care or complex cases?
That's the best part. DeepScribe's proprietary LLM, Keel AI, is trained on over 3 million patient conversations. It's then further tuned by specialty and subspecialty cases, making it way more accurate than GPT-4-based solutions. Pair that accuracy with DeepScribe's customization studio to personalize the experience for different clinician preferences and workflows, and it becomes incredibly flexible.
Alan, speaking of flexibility, I could use some yoga myself. Flexibility is key when it comes to working with health systems with so many moving parts. DeepScribe sounds fantastic. Where can health systems learn more?
About your yoga? I don't think they want to. But about DeepScribe, check out deepscribe.ai. That's deepscribe.ai to learn more.
I'd love to maybe dig a little bit to some of the technology stuff that you're thinking about right now. So you might have heard of this thing called AI. I've been hearing a lot about it the past year.
A little bit, yeah.
A little bit. Hot topic, of course. Curious your views on what are the really great, low-hanging fruit, high ROI use cases for AI in healthcare? And then are there any use cases right now that you feel are kind of overhyped, maybe are too far in the time horizon to really look at?
Yeah, certainly it's changed a ton over the last 2 years. Asked me about it 2 years ago, I had a different answer. But what we've been doing really is leaning heavily to the ChatGPT, the ambient scribe technologies. I think, for physicians, that's the lowest hanging fruit. And, we've seen the adoption really kind of explode here and then across the country, talk to the colleagues, just eliminating that hour a day of having to write additional notes is a game changer for a lot of our physicians. And I've had several that said they were nearing retirement age, that this is going to extend their careers for who knows how long, how many more years. So, which is, for us in particular, we have a primary care physician shortage. It's kind of the same around the country. An aging primary care workforce, it's really crucial for us right now to be able to use this. And so we're leaning into it heavily and expanding that as much as we can, and going to keep looking for other ways to use that sort of technology to help summarize notes, help nursing workflows even in the future. So I think there's a lot of opportunity there. And it's been written about for a while. Some of the things that maybe it's too early, even though it's scary. I mean, you see these same LLMs that are passing all the boards, they're doing better than doctors on all these clinical reasoning exams, et cetera. But I don't think they're going to replace doctors anytime soon. I think that's still far off, even though they have that knowledge and may be able to help with aiding diagnosis. There's so much more to medicine than just making a diagnosis, which I think we're a ways away from automating everything else. So yeah, that's kind of where I am on the two kind of extremes for potential with AI.
Yeah, it's funny because I think the idea that you could equate being good at test taking with being a good physician, I mean, they're not the same.
Right.
You need to be competent from a knowledge point of view, but it's certainly not the same as managing a real live patient and everything to do with it. But it's impressive. It's definitely impressive. I guess one of the things we hear about is, right now, AI is interesting for administrative, let's call it lower risk use cases where it's okay if some mistakes were made. But when it comes to, let's say, direct patient care, it's higher risk. You might have a higher threshold for safety. What's sort of your threshold for when you actually would be okay with, let's say right now, like chatbots, right? A lot of health systems have chatbots on the website for self-scheduling and basic support. There's no clinical risk there. But a chatbot for actually communicating with the patient about their actual treatment plans or what to do around clinical care, what would have to happen for you to be comfortable with that, do you think? How far do you think we are or close we are to that sort of world?
I mean, I would love to see, an actual randomized clinical trial, I guess, that would use it and compare to the standard of care and whether it was better or worse or caused harm. I think it's just going to be a question that is lingering in artificial intelligence, not just in healthcare, but elsewhere. And there's currently lawsuits around who was at fault for Tesla's AI that ran over somebody. Was it the algorithm, or was it the person in the car that was asleep at the wheel? I think that was the case. So, look, maybe those sorts of test cases will get ironed out before we introduce it in that regard to healthcare. There's already bits and pieces of it out there. There's all these clinical decision support algorithms that are built on AI that would suggest a course of action. Maybe it's just labeling a patient septic or not septic, but that may have downstream consequences if somebody acts on that advice and causes harm. Who is at fault there? So, short of, I don't think we'll ever get to a point where it will be 100% safe to, just allow free reign or just have somebody, off the street with no medical training administer drugs based on an AI's response. But it's certainly something that's going to have to, one, be answered in randomized clinical trials to show its effectiveness and safety. I think it's very important that happens. And then it's going to be something that is probably going to be held up in the courts for a long time, is my guess.
Okay. You brought up a really good analogy with Teslas and autonomous driving, because to your point, if there's an accident, who's liable? Was it the human should have been, let's call it the co-pilot at the end of the day? Or, is Tesla liable? Because based on that precedent legally, that might inform how they deal with things in healthcare. Was the physician a co-pilot, or was the patient autonomous with the AI? That's a really, very great analogy. I'm sure there are lawsuits now, right, that have come out. So, depending on how those go with Tesla or the other autonomous cars.
Yeah, I bet that forms the precedent for other things that may come. It's certainly going to be interesting to see how it unfolds. Again, I really think people do better when they're added to the technology. It's technology plus people versus just technology alone. So I don't want to remove that human from the loop as long as it makes sense. And based on all the studies I've seen, it's really that it's the AI plus the human do better than the AI alone or the human alone. It's the same with chess, right? So, none of us, not the best player in the world, can beat an artificial intelligence in chess. But at the same time, a human using that AI can destroy any artificial intelligence alone out there. So I think it's going to be the same in healthcare. And there's going to be, I think ultimately the responsibility should be on the human that's using the technology, that has the training, because otherwise the incentives won't be there for people to keep innovating and developing these algorithms to improve in the future.
The one thing we know that's true is that no one will want the risk. That's the one thing that we know is true. So everyone's going to try to pass on the risk to some other party. It's no fun to be the one at fault. So I get that.
Yeah. So Jake, while we're on the topic of looking to the future with AI, I'm curious to get your thoughts. You mentioned in the past the potential transformative impact of rebuilding an EHR from the ground up with AI integration throughout all of the workflows and all the processes. If you had a crystal ball to look into that future, how would that look to you?
Yeah, I guess when I was thinking about it, you think about GitHub and its partnership with Microsoft and suggesting code and just how more efficient our programmers have gotten outside of EHR development with, being able to write code with AI. That doesn't really exist with the majority of our large vendors for healthcare EHRs. And it's still a very antiquated process for building out things within our current EHR. And I just think that probably the current design might not lend itself to facilitating those two pieces working together. But you could imagine something that was built from the ground up to use this that would eliminate a lot of the pitfalls we currently have with unstructured data and where that lives and getting that to registries and other quality reporting metrics that we literally have hundreds of people combing through every day in order to report on this data. If it was built around AI and the AI was able to more efficiently change that from unstructured to structured format, I think that would have a large impact for a lot of places. And same with coding and documentation. I think, we have, again, hundreds of teams that are going through and pulling this data and really trying to make sure that we're compliant and billing as effectively as we can, given the rules. I think having it with AI in the background, helping and enabling, you may be able to eliminate a lot of the humans that are in the background having to do this work, as well as make the notes more useful. There's just a lot of different things, and hopefully some speed that can happen too, that not everybody's having to reinvent the wheel over and over again on building the same modules out or the same workflows out in their EHRs when there should be a large database of all these different workflows that have already been built out that they can use AI to suggest builds and things of that nature. I think there's potential, but I'm not confident that the current designs of them will enable it.
Right.
That makes sense.
Yeah, it does. I like that analogy of the GitHub and Copilot. So it's more like using the AI within the EHR to build on top of and modularize pieces and have templates more or less suggested. I love that. Yeah. The last question that I had for AI in this space, you've talked in the past about finding this sweet spot to pilot different initiatives. So you don't want to necessarily have the most tech savvy people that don't have challenges with, let's say, like clinical documentation with ambient. And so they're not necessarily the best for pilots. So I'm curious, what are kind of your latest learnings on identifying the right champions for some of these initiatives?
Yeah, so early on, prior to so we use DAX, and we had DAX, what's called full service, that it was part AI and part remote scribe that would help write the note and put it in. And then we, recently moved to DAX Copilot, which is the full AI version. Early on, it was difficult to find the right physician to use it. So I have my group of tech-savvy physicians that are interested in informatics and those things that join my calls about optimizing our EHR. And I didn't necessarily want those doctors to do it because they were already efficient and we wouldn't have been able to show much of an ROI by moving them to the platform because they were already very efficient in that they were getting their notes quickly and weren't spending a ton of time there. There were a handful that joined from that group, but I really wanted the more average Joe physician that was less tech savvy, that we could show that these tools actually worked. Because any of my tech savvy physicians would be able to adopt them, but you really wanted to show that the average physician was able to. And so that's what we were able to do with Copilot. We had several that were over the age of 60, maybe in more of that demographic that would shy away when you mention artificial intelligence, but we were able to get them in, and they're the ones that are sending me, the thank you notes related to extending their career. Certainly, you can go too far on that extreme. You really need to have somebody that is willing to learn and willing to be approachable to new technology, but at the same time, you don't want somebody that's the early adopter either. You want maybe a mix of a little bit of both. And then there's a handful that, tried it and they think, yeah, this could work for me, but I'm decently efficient already. I give it to somebody else, or some that they tried to get it to do it and they just never really were able to, make the commitment. And so you cut your losses and get it out of there. But I think realizing that for a lot of your technologies, you need to find the more average user versus your tech savvy ones to start with. You do need some early adopters to really promote and encourage, but you need to move pretty quick to the others.
It's almost like also like you like having a variety of different clinicians, whether it's different tech savviness, ages, specialties, all that, because you end up with like different, let's call it clinician phenotypes, because then you can kind of figure out, okay, who gets the most value out of this based on different characteristics. It's almost like targeted, like personalized patient interventions, like personalized clinician interventions. And I think, people would be surprised. Like, I think you're right. People have found out, hey, the tech savvy people didn't benefit so much. They were so adept at using documentation in the EHR already. And then people are surprised by there are older folks who actually benefit a lot. Who would have known, right? It's really fascinating.
Yeah, certainly the specialty plays a big role. Certain specialties just lend themselves more easily to the adoption of this. For our case, it was primary care. The surgical ones that didn't have a ton to write, it didn't benefit them that much. And they were in the OR a lot anyway, so it just wasn't as useful for them. And then some just have very strange habits that like to keep a run. I don't know if you've ever come across these docs that like to keep a running history, and every note is a complete chart history of every patient, every new note is. And so that's just one habit that you can't break even with this.
Can I ask you, so obviously Al and I, we're not practicing clinicians. We don't get to use ambient or cells, but I was kind of curious, as a clinician, can the model be kind of tailored or to each individual clinician? Because is it learning Dr. Lancaster's preferences, or is it more of a generic model that, Baptist gets to decide the same, model or prompts in the background that everyone has to be using with it?
Yeah, for the ambient listening, it's not Baptist specific or physician specific. It's more the broader ambient community that is all using the product, and they will update it monthly. So for instance, over the last few months, the first time I used it back in early February this year, the language was just not what I would be used to writing. For instance, it would use more layman's terms, patient-friendly language, even the assessment plan where I really wanted to drop the medical ease, and really show my thinking. It would really put things a little too simply for physician-to-physician communication. Yeah. But they made an update recently, and now one doctor described it as they took the scribe through medical school is what it seemed like. And now everything is maybe a little too far on the other extreme where, it would a little too formal medicalized language versus something the patient would typically say. Either way, I kind of like the new version a little bit better. It makes you sound smarter when you're writing it, but it does adopt, if I go in and edit what it has written, apparently that goes back and feeds the model for future development, but it doesn't learn my style. And this isn't the only one I've used others, and they all do have a different style, and it's never the way I would write it, but it's, some of them are maybe a little bit closer to your personal preference than others. But yeah, it's something you have to get over. If you're somebody that is very particular about how you write your notes, it's also something that's probably not going to work for you because they're not going to phrase it how you would like to phrase it.
Today's episode is brought to you by SeamlessMD, which enables health systems to digitize patient care journeys, leading to lower lengths of stay, readmissions, and costs. Josh, you used to be a doctor. Did you ever feel like patients showed up unprepared for surgery? Or maybe you felt like you were sending patients into a black hole after discharge?
All the time. We give patients paper and verbal instructions, which are so easy to forget and really hard to follow. And we have no idea what happens to them outside the hospital. So what happens? Well, because we worry about them, we keep patients in hospital longer, but that drives up length of stay and lowers throughput. Plus, after they leave, patients get readmitted for infections and all kinds of problems that we could have just caught earlier if we monitored patients.
What if I told you there was a way to give every patient a virtual companion so you could automatically engage and monitor them through a surgery, a cancer journey, or a chronic care journey, and drop the length of stay, increase throughput, and lower readmissions?
Gosh, Alan, that would be amazing.
So that is exactly what SeamlessMD does. It allows health systems to engage patients on their own phone, tablet, or computer with automated reminders, education, and symptom monitoring. Basically a GPS through any healthcare journey.
That sounds fantastic, but does it actually work?
It does. Health systems have done over 40 studies and evaluations showing how they use the solution to reduce length of stay by 1 to 2 days, readmissions by up to 89%, and costs by over $1,000 per patient.
But how does that work with my EHR?
That's the best part. SeamlessMD is the only solution in this space with direct integration partnerships with Epic and MyChart, Oracle Cerner, and Meditech.
Well, I am getting a colonoscopy soon, so I really need something like this. Where can my health system learn more?
Well, Josh, thanks for letting me know. Your health is very important, and endoscopy is just one out of the 50+ out-of-the-box care plans available today on SeamlessMD. Go to www.seamless.md. That's www.seamless.md to learn more.
You also brought up a good point a few minutes ago about depending on who you talk to, if you mention that there's AI involved, it may put them off. And it made me think, well, maybe when we're communicating this to clinicians or even patients, we should, depending on the person, we may or may not want to focus on AI, just focus more on what's the job to be done that we're helping. Yeah. So like, if you have some tech-savvy docs who love AI, maybe you should mention this AI. If there's others who, are adverse to AI or technology in general, you focus more on the value, like, hey, this is going to, automate the summary. Because at the end of the day, AI is just a tool, right? I'm just wondering, it's
a good point. And I've found myself, when I'm trying to communicate that this is available, changing the way I describe it, depending on the audience, and kind of beta testing some of the feedback I get. Because, artificial intelligence scribe, ambient scribe, automated note generator can be off-putting to some. Like, people know what ambient scribe is? No, but that's the term that is in the industry right now. But the average physician, they don't know what that means. But if I tell them, they know what a scribe is, and then you kind of work backwards from there. But really, at the end of the day, you kind of, even after I've had these conversations, I don't know, hundreds of times, and I think they know what I'm talking about, they don't until I show them the actual demo of the product of what it's doing. And it's happened so many times. I'm just like, I don't think you really understand what I'm talking about. Let me show you. And that helps. Yeah.
My favorite thing is like when you go to like a company's website and then you read the taglines and how the company describes the product and what it does. And I'm in healthcare and technology and I can't even understand it sometimes. But if that same company were to ask their users how they would describe the product to a friend, it actually makes sense. Yeah. You can explain it in like very simple everyday terms. And then you're like, maybe that should be the tag on the company website, right? Exactly. Like maybe we shouldn't call it ambient because, your everyday clinician doesn't even know what ambient is. I don't know. I'm just like thinking out loud, but it makes me think of that when you describe those stories.
No, I like the idea. Maybe I should ask my colleagues how they describe to their colleagues, and steal their terms. So,
yeah. Jake, the other thing that I appreciated in a previous conversation that you had is sometimes the solution is low tech or no tech. And one of the strategies that you use to at least diagnose what was going on with clinician burden and staff shortages, one of the strategies was to have I believe you dubbed it efficiency engineers, actually go around following the nurses to understand their workflows and really understand what's eating up all of their time. Can you tell us more about that approach and what maybe some of the most surprising learnings have been?
Yeah, I mean, going out and actually seeing the work and speaking with the people that are doing it and what their problems are, I mean, that's just, it has to be a core part of your job if you're in this space and you're trying to make improvements. Every time I go, I learn something new. And I'm going to talk about the efficiency people in a second, but just majority of the time that I go meet with a struggling physician, I don't have to come back and ask our build team to create some brand new workflow or make all these changes. I'm just able to show them some really simple things that I thought were common knowledge that they were not aware of. And just because our EHRs are so complex, there's, the learning curve is pretty high. Even for somebody that's been using it for 5 or 6 years, there's just things that in shortcuts that they don't know were there that you may know. But yes, so the project that you're referring to was our Project Joy, which was an initiative, still is an initiative to decrease the amount of time our nurses were spent documenting. And so led by our system medical director for nursing. And we have here at Baptist, our chief improvement officer for the system has several people with a background in engineering and healthcare engineering that are able to look at processes, draw the little spaghetti maps, if you've seen those, about, where the bottlenecks, where they spend the majority of their time. And so we were able to have them follow around nurses, and based on their feedback, we were able to make a lot of small changes, some small, some big, that saved upwards of 20 minutes per shift for our nurses that really didn't involve much technology. For instance, one of the things was just the amount of time they spend going to get medications and where those medication cabinets are, or if they have to go to the central pharmacy to get it. How can we decrease that amount of time? Because that was not an insignificant amount of time. It was 10+% of their shift was spent doing that. So any way we could reduce that actually gives them a lot more time. And so some of it we actually had pharmacists or pharmacy techs move the medications to the nurse instead of the nurse having to go out and do that. And so that works in some ways. And then even just centralizing some of the way we do discharges and telesitting is something new that we have in now, where we have just a video that is able to interface with the patient and help with the discharge paperwork. And that has freed up a lot of our nurses' time. Or the telesitting approach, where we just centralize that in our corporate office for our 22 hospitals and free up a lot of nurses that way. So that helped a lot with our staffing shortages. And then, there's been some cooler things that came out of it. We now have this robot pilot that is essentially a nurse on a stick, is what we like to call it, nurse on wheels, that we control centrally, that is able to weave up out of the corridors in the hospital, up the elevators to the patient's rooms, to do things like the nursing assessments on admission. So that one is a little bit more tech than what you were looking for, but it's basically a camera on wheels in a motorized car that's been around forever, but it's something that's been fun.
What's really cool about that efficiency engineers approach is you have these, frontline staff members who, if you ask them, like, why are you doing it this way? Why are the medications there? You're going to them. I mean, the answer probably is like, well, we've always done it this way, and we're just so busy just take care of patients, we don't stop and think about it, or we're just so used to it. And you have these like outside folks who come in who have no preconceptions about how things should be, and they're like, like, why do you do it that way?
Yeah,
totally fresh approach. And you sometimes you need like an outsider almost to identify like stuff that doesn't seem quite right or could be better. So that's really cool.
Yeah, another one that was, so low tech and so obvious when you think about it at the end is each of our supply rooms on every floor is ordered and structured a little differently. And, some of them, they never really thought about the human factor when they're stocking these things either, about how it's laid out. And so having them go through and it's like, oh, look, our short nurses can reach this item and it's used more frequently. Why don't we move the more frequently used items down, here where they're able to be accessed easier, and move the other ones that are rarely used off into the right. And then, yeah, why are they different on every floor? Or why can't we have one design layout for the entire hospital? That way, if you have nurses that are traveling between different floors or working different floors on occasion for different shifts, that everything will be, the same. Just like maybe if you go into Kroger or Target or somewhere in a different city, it usually will have the same layout. And so you know where to find the milk and the bread when you're going through. And so trying to take that same approach to just stocking supply shelves, and it's made a big difference.
There probably is so much low-hanging fruit that unless you actually go in shadow and watch, like we have no idea whatsoever that it's there.
Yeah, no, it's go and see. That's go to the Gemba is what they say. So it's a novel approach. Actually see how the work's being done, and you can understand how to do it better. Yeah.
I love that.
Amazing. So Jake, obviously hospital at home is really gaining traction, and I've heard you say in the past that you think that is the future. Like, let's get the non-complex patients, at least get them help at home where they want it most. I'm curious, what future developments do you see regarding data and technology and how we can further support patients outside the hospital?
Yeah, I mean, I still think it's nascent industry that I'm hoping will grow more. Early on when CMS during the pandemic was kind of approving what could be treated in the home versus the hospital, it was a very hard patient to find. So they would have to be sick enough to be an inpatient, but really not sick enough where you were worried that they were going to have a bad outcome and want to keep them in the hospital. So that really limited the number of diagnoses that you could have. And we actually had trouble staffing our hospital at home program because of that. It was a chicken and the egg problem. We don't have enough patients to warrant allocating our scarce nursing resources, which have rebounded some, but are still not back to really pre-pandemic levels, to this role. So I think, one of the future directions is really just kind of reevaluating some of those criteria of what can be included and what cannot. And I think technology will help with that. There's a number of companies that have sprung up that cater just to this space that give you a little bit more comfort with having a sicker patient in the home that meets the criteria for admission for the regulations, but also gives you that peace of mind that they're not going to have to be transferred in for, emergent surgery or an escalation to the ICU. So, I think a combination of continuing to look at the regulations about what is allowed and how we can make it better for the hospitals, more incentives for the hospitals to do this, because we still have, I don't know about places you work, but we still have bottlenecks in our ER across our system. Patients, waiting for beds, and it's not getting any better. And plus, patients do better when they're at the home. All the studies have shown patient satisfaction's increased, lots of improvements. Hospital-acquired infections are down there, just because you're not around other patients that are having the same infection. So, combination of those companies continuing to grow and support the programs, and then advocating for more flexibility in the requirements, I think would really help move it more into the mainstream.
Totally. So last question that I had, Jake, you are now a published author. So you recently wrote the book, The Matter of Medicine, which reimagines, I believe, the Arthurian legend in a modern healthcare setting. Really cool idea. So I'm curious, what inspired you to write this book and really blend those kind of narratives together? And what maybe key message do you hope readers take away?
Yeah, so, great question. Something I've been asked a good bit. My father wrote a book, and so that was kind of the inspirational, I have to write a book. My dad wrote a book, so that was the start of it. And I'd always liked writing growing up. And then when I was actually doing that master's in health administration, I was reading The Once and Future King. If you've read T.H. White's book, it's one of my favorites. And I started just with the analogy that hospitals are kind of like castles. There's these large, complex structures, knights kind of very similar to physicians. Patients come here and just like, a siege almost on the castle. And so it started there. And then it was back when I was in fellowship, there was some competition that got posted on Twitter where you could win like a 2-week stay at some secluded house in England for writing if you had, the best, I guess, one-line tweet about what your book idea was. And I unfortunately didn't win, but I started writing it during that competition. And it really, I liked it. I liked the practice of it because healthcare is so hard. There's so many frustrations. And so much has been written on the nonfiction side about healthcare and its problems and potential solutions. But it's so much easier just to reimagine things with the flick of a pen, to imagine what the ideal could be, what you would want it to be, what would Camelot be in healthcare. So it was a great growing experience for me. I learned a lot. I learned a lot about what I thought were the problems and what potential solutions there would be. And I just encourage more physicians to get involved in the fictional side, the creative side. It's something it kind of gets beaten out of you during medical school and residency. Any creativity you had, it kind of gets lost. And it's good to be able to come back and try to build something again.
Who's the ideal audience? Like, is it meant more for like practicing clinicians, or like anyone would be a good reader for it?
Well, so the ideal audience would be somebody that is very familiar with healthcare, very familiar with the Arthurian or the legend, and really likes 90s music. So
just the three of us.
Yeah. So, that originally I had all the language, all of the conversations were 90s lyrics, just song lyrics. And I just took them in different spaces. And you can kind of see that when you read it. I did go back and, after getting some advice from an editor, changing all of that because, copyright violations and things of that nature.
Right.
But I think it's anybody, I think you could get enjoyment if you liked, just fiction, if you liked the Arthurian legends. Certainly if you were interested in healthcare, you worked in healthcare. I know a lot of nurses that commented on it and how they've, like the descriptions. I think that is the kind of the target audience, but, it's certainly niche in some regards, but, SeamlessMD did it. So, why can't we do it?
True. So without spoiling the story, can I ask you, what percent of the time does Arthur spend documenting the EHR in this story?
Oh, that gets solved towards the end of the book. Actually, Mordred, who's, if you know Arthurian legends, that's his kind of his enemy, the villain of the story. But he's actually in health IT, and so there's a blend between me and Arthur, the good and the evil side, I guess.
Yeah, that's awesome.
Nice. Yeah, I love it. So, Jake, just being mindful of your time, we're going to flip over to the Fast 5 lightning round. This is just 5 kind of rapid fire questions for you. First question we have, and I'm so curious to know your answer, but what is your favorite book or book you've gifted the most?
Yeah, favorite book, it was one I just mentioned, the one from Future King, but T.H. White. I wouldn't say it's the one I gifted the most, though. Whenever somebody asks, especially in healthcare, I send them a lot of Eric Topol's books, especially some of the later ones around artificial intelligence. I think it's certainly relevant right now.
Yeah, definitely. Question 2, who is a person, either dead or alive, who you'd love to meet?
Person dead or alive I would love to meet. I would say, again, I like writing, and when I read this the first time, the name that came to mind was Kurt Vonnegut.
Nice.
I love his writing. I do not write like him. I could never do that, but I just love the way he writes, and I love his all of his works.
Yeah, amazing. Question 3, would you rather have super strength, super speed, or the ability to read people's minds?
I can go with super speed. I still run a lot, and I like to do speed workouts, but I would love to be even faster. And I can always get around the super strong people, and I have no desire to read people's minds. I think that would kind of be more of a curse than a blessing.
Yeah. I think there's a Twilight Zone episode on that, maybe.
Yeah.
But anyways, question 4, what is something in healthcare you believe that others might find insane?
Gosh, there's so many different things in healthcare that others might find insane. I'm sure the use of pagers and fax machines is pretty wildly known, but those are still things that are insane that we do, and we have come to accept it, and very little is done about it.
Mm-hmm. Last question that we have, if you could travel back in time to any event or moment, what would it be and why?
This is a tough one. Could I go back as far as the Big Bang? I think that would be pretty cool to see. I don't know. I'd have to have some sort of protective suit or something, but, see how it all began.
Yeah, that'd be cool.
Yeah.
Awesome. Well, Jake, thank you so much for spending some time with us today. I definitely learned a lot, and I hope that our audience took away lots of these pearls of wisdom that you shared. You can find Jake on Twitter or X at Jake Lancaster MD. And that's a wrap for this episode of The Digital Patient, hosted by SeamlessMD. You can follow us on Twitter at SeamlessMD. And if you like the podcast and you want to learn more, visit www.seamless.md. Again, Jake, Dr. Lancaster, thank you so much.
Yeah, thank you for having me. I really enjoyed it, guys.